All right, good afternoon everyone. Now before we start discussing electrolytes, let's see how much you remember from last time. Okay, so quickly we look at a case. A 40-year-old man was brought into accident and emergency department late at night in comatose state. No history could be obtained because he's comatose. Clinical examination was also difficult, but he smelled strongly of alcohol. And these are the lab results. Okay? Have a quick go through and then I'll go to the next slide. What is the most striking thing you see here? Osmolality is way above the normal value, right? So basically what you see here, osmolality is very high. What will you do next? If you get this kind of lab report, sodium level is normal, osmolality is very high. What would you do next? How can you calculate osmolality? How do you know osmolality? There are two methods, right? You can either directly measure osmolality from serum or plasma, preferably serum, or you can use a formula putting in sodium, potassium, urea, some other stuff, and you can calculate osmolality. Remember or not? Yes. Is it ringing any bell? Okay, good. So you calculate osmolality and you compare it with this osmolality which was directly measured in the serum, and you see if there is, can you calculate for me here quickly? It's somewhere around 290 plus, somewhere around 290 plus. What is the difference between the measured osmolality and what you are getting through this formula? The difference about 170 something, right? If you see such difference in measured osmolality and the one that you calculate, what is the significance of this? This is called high osmolality, high osmolar gap. What is the significance? What does it tell you? That there is something in the blood which is contributing to osmolality, right? But when you put it, when you use the formula to calculate, it is not there, but it is present in the blood. In this case, going back to the history, what do you think that could be? Ethanol, right? Alcohol, ethanol. So there's a lot of ethanol in his blood. There is a high osmolar gap. So in this case, it is due to presence of ethanol in blood. So remember that. Okay, very common in clinical practice. Today we'll be talking about electrolytes. We touched upon electrolytes last time when we discussed osmolality. We were talking about sodium a lot, which is one of the major electrolytes. Today we will look at them in more detail. All right. So we'll be focusing today on sodium, potassium, and chloride. And towards the end, we talk a little bit about anion gap. All right, and the second lecture will talk about the remaining three major electrolytes. Okay. Now, if you remember, we have two major compartments of water: intracellular fluid and extracellular fluid. Which ions out of the three we are discussing today, the sodium, potassium, and chloride, which one is in high amounts inside the cells? Potassium. And which one is high outside the cells? Sodium. And what goes with sodium? Chloride. They have very strong friendship. Okay. So potassium is very high inside, low outside. Sodium and chloride are low inside but very high outside. Because sodium is very high outside, so it plays the most significant role in determining osmolality. In determining osmolality of blood. Is that clear? All right? Okay. what information we can get by measuring these electrolytes in a patient's blood? They can of course tell us about fluid balance and osmolality. Is there movement of water into a compartment where it should not go? Remember, first spacing, second spacing, third spacing, water can move to different areas. They can also tell us about some cellular or organ function, plus acid-base balance. So, when we discuss acid-base balance next time, then we will see how electrolytes can also inform us about acid-base disorders. Okay, but their main role will be in determining fluid balance and osmolality. Okay, what regulates electrolytes? We have discussed this last time. Kidney, right? Kidney plays the most important role in either conserving water or getting rid of extra water, conserving sodium or getting rid of sodium, conserving potassium, etc. So, kidney plays the most important role in regulating major anions and cations. Sodium water balance is the main determinant of fluid electrolyte reabsorption, and we discussed those few hormones which are important last time. ADH, aldosterone, ANP, atrial natriuretic peptide, which is opposite to the two. Okay? So, these are major hormones. We can also lose water and electrolytes to other routes, for example, GI, skin, and also to some extent through respiratory tract. But these are small losses, and these are not really regulated. But the kidney's loss of water or gain of water is very tightly regulated because of those hormones. Okay. And this picture we discussed last time. Just to recap, so you have ADH, also called vasopressin, you have ANP, you have aldosterone. Okay. So, all these different regulatory mechanisms will determine how much water is lost from the body or how much water is conserved in the body, right? Now, what we will do, we will look at sodium first, then we will go to potassium, and then we go to chloride towards the end. Sodium is the most abundant extracellular cation, all right. Very small amounts are present inside the cell. There is no storage of sodium. There are no sodium stores in our body. So, every day we take sodium in our diet, and every day we get rid of some sodium. Okay. It is the greatest contributor to fluid balance and osmolality. We have discussed it previously. It also plays some role in cell membrane stability, electrical signals, as I just mentioned to you, nerves, muscle tissue. Okay, also helps in functions of receptors, channels, and cellular transport system. Okay. Now, based on our previous discussion, remember we talked about these fluid disturbances, 6 examples. We discussed about these loss of fluid or addition of fluid in the ECF, and then we discussed when you add fluid into ECF or take out fluid from ECF, what happens to ICF, depending upon what is the osmolality. Okay. If there is loss or gain of pure water from extracellular fluid, and the main compartment from which you can lose is blood, right? Whenever you have an injury or something, the fluid is lost from blood vessels, which is extracellular fluid. If you lose or gain pure water, I can also put here hypoosmotic fluid, which means there is more water lost than sodium lost. Okay. So, if you lose pure water, the loss or gain in both cases, whether you lose or you gain pure water, it will be distributed across all fluid compartments. So, if you have gained 2 liters of water, okay, some of it will go to ECF, some of it will go to ICF. It will be in both. If you lose pure water, you lose from both compartments, ECF and ICF. Because of osmolality, the water will move. Okay. But if you lose or gain sodium and water, which is isotonic, so equal amounts of both sodium and water, if you lose or gain, the only thing that happens is to the ECF alone. So if you take isotonic fluid, it will add up to the ECF volume. It will not move into the cells. Only your ECF compartment will become larger. If you lose isotonic solution, your ECF compartment will shrink. Water inside the cells will remain there. There will be no movement of water between ECF and ICF. So these two are important points to remember from last week's discussion. Right. Now, talking about sodium. Sources, as I just mentioned to you, mainly it's oral, dietary intake, could be iatrogenic. Patients who are in hospital, they are getting some sodium chloride infusion, so you can have some sodium introduced to them. Renal reabsorption actually is not a source, but through which you can actually save sodium and bring it back to the blood. Okay? Loss usually occurs through urine. It can occur through skin, GI tract in case of diarrhea or vomiting. But this is usually limited and this is not regulated. So mainly kidney will regulate how much sodium you keep in the body or you allow it to leave the body. Okay? All right. And in the kidney, if you remember, we talked about this last time as well. When there is filtration, almost 65 to 75% of sodium will be reabsorbed very quickly in the proximal tubule. Small amounts will reach all the way to this part, and this part, the reabsorption is dependent upon ADH and aldosterone. So if you have aldosterone hormone there, it will reabsorb sodium and water will come with it. If you don't have aldosterone, you will have more sodium leaving the body in urine. Same for ADH. If ADH is there, it will bring back water and some sodium. Okay? But remember, ADH mainly reabsorbs water. Aldosterone reabsorbs sodium. Water follows it passively. Okay? Important point to remember. If the serum sodium concentration increases, which means there is hyperosmolality, and we discussed this also last time, it will stimulate osmoreceptors in the brain. They will sense there is increased osmolality. They will lead to increased secretion of ADH, which will go to the kidneys and reabsorb water. When you reabsorb water, you add water to ECF. Okay? You add water to ECF. What will happen? The sodium concentration will go down because you are adding more water to ECF. So you are diluting the sodium. All right? So ECF will get diluted, sodium concentration will come back to normal. If opposite happens, which is there is decreased sodium in the blood or hypoosmolality, the osmoreceptors will be inhibited, they will be decreased in the secretion of ADH, you will have decreased thirst, increased urinary output, and you will lose water. ECF will get concentrated, sodium concentration will go back to normal limits, right? Now, water intake is mainly regulated by thirst and water output is mainly regulated by ADH. Now, normal serum sodium levels, this is the range 135 to 145 millimoles per liter. In the urine in 24 hours, there is a wide range. Varies with diet. Somebody who is having high sodium diet will be excreting more sodium, of course, right? CSF is very similar to serum or plasma. Okay? Now, laboratory methods which are used to measure sodium can actually either overestimate or underestimate sodium, the older methods. Sample collection site, very, very important. Patient is in the hospital, there is an IV line, okay, over here in his hand, and you're taking sample from the vein over here. So serum sodium levels will be normal? No, right? Sample storage, all these things we discussed last time. Okay, also physiological status of the patient, stress, surgery, trauma, drugs, all can interfere with sodium levels. If you are taking sample from a patient where you think one of these are present, you take note of these. Okay, the patient has come out of surgery just 6 hours ago and you have taken the sample, you make a note that post-surgical sample. Okay. There are many drugs that can affect serum sodium concentration. Students especially who are in pharmacy program, okay, please take a mental picture of this slide and never forget it. All right. So drugs that increase serum sodium is a long list, and drugs that can decrease serum sodium is over here. Okay. And you see vasopressin is listed here. In some cases you may give the patient ADH injections. All right. So it's then counted as a drug. Okay. Now let's look at the problems with sodium balance. First we look at hyponatremia, then we look at hypernatremia. Take note of this point over here. This is the commonest clinical biochemical abnormality you will see in practice. Very, very common, hyponatremia. Now, hyponatremia, what do you think? What can lead to hyponatremia? You imagine a glass of water and you have some sodium in the water. Okay. How can you reduce the sodium concentration in this glass of water? There are two ways. Either you take out some salt from the water, or you add some more water to this solution. So two ways you can reduce sodium concentration, right? So you can either lose sodium chloride, so you will have hyponatremia, okay, and there will be dehydration. Okay, why there will be dehydration? You are removing sodium, right? Why there will be dehydration? Because sodium will take some water with it. Remember, so wherever sodium goes, it takes water with it. So if you are removing sodium from plasma, from blood, it will take some water with it. So you will have hyponatremia and dehydration together. Second thing you can do is, if this person keeps drinking water, so you are diluting your ECF, the total sodium remains the same. But because you have added more water, the concentration of sodium has gone down. Again, referring back to those 6 disturbances we discussed last time, this fits in that picture. Hyponatremia with dehydration, adrenal insufficiency. So you are having lack of aldosterone. When there is lack of aldosterone, you cannot reabsorb sodium from the kidney. Sodium is going out in the urine. So there will be hyponatremia. It will take some water with it. So you have hyponatremia and dehydration. Okay. Same thing can happen if somebody is having overdose of diuretics. You are losing a lot of sodium and also losing some water. But remember, you are losing more sodium than water. If you were losing same amount of sodium and water, there won't be hyponatremia, because then you will be removing isotonic solution. The concentration of sodium will not change. So you have to lose more sodium than water. Only then you will have hyponatremia. You got this point? Okay. Second possibility, hyponatremia with overhydration. You have a lot of ADH. A lot of ADH. What ADH does? Brings back a lot of water into the blood. Pure water. When water is coming, sodium gets diluted in the ECF. So you have hyponatremia together with overhydration. Okay. Bronchogenic tumors, because these tumors are notorious in producing ADH. They can produce some ADH. Right? Now, if you look at the list of causes of hyponatremia, there is a long list. Okay, I don't expect you to remember all these causes. Nobody can, but just to let you know an important point. You see, hyponatremia can be classified based on osmolality as well. In the first slide, I showed you hyponatremia with dehydration or hyponatremia with overhydration. Did you get that point? Nice and easy. Another possibility is there. You can have hyponatremia with low osmolality, makes sense. Sodium goes, osmolality drops. Right? Sodium goes, osmolality drops. This is very easy to understand. Okay. With normal osmolality. Now, in this case, what has happened? Sodium has gone, but there is something else in the blood which is contributing to osmolality. Like you have extra lipids, you have extra proteins, okay, you have extra magnesium, you have extra calcium there. So, in these cases, even though sodium has left the blood, the ECF, but something else is making up for the osmolality. So, you can have normal osmolality, but still hyponatremia. Okay. Then you can have hyponatremia with high osmolality. Okay. This is a case of hyperglycemia in diabetic patients, a lot of glucose. Sodium is lost, but there is so much glucose that osmolality actually has gone up the normal limit. So, you can have hyponatremia with hyperosmolality. Syndrome of inappropriate ADH secretion, I mentioned to you as one of the cause earlier. Either the ADH is being released, there is inability to suppress its release, there is inappropriate continued secretion. Okay, this will lead to impaired water excretion and subsequently water retention and hyponatremia. Important thing to remember here is that this increased ADH secretion can occur in patients with stroke, can occur with certain infections, with brain injury, in psychosis, pneumonia, adult respiratory distress syndrome, post-op and drugs. Why I have underlined this one, post-op, because this is very common. In surgical wards, after surgery, when patients are shifted to the ward, right, there is a tendency to give them a lot of fluids. But what happens in post-op situation, the ADH secretion actually is increased. So, patient is reabsorbing a lot of water. Sometimes what we do, we overhydrate the patient. So, you have to be careful in post-op patient, do not overhydrate the patient. The ADH is already reabsorbing water from the kidney. Okay? Ectopic secretion like lung cancer, as mentioned to you earlier, or some drugs can actually increase sensitivity to ADH. So, ADH amount is low in the blood, but kidneys become more sensitive to it. So, they will reabsorb more water. Okay. Everything okay until now? Okay. What happens when there is hyponatremia? When there is hyponatremia, there could be cell swelling. Why? Again, remember when we discussed last time, the tonicity. If you put cells in a hypertonic solution or a hypotonic solution, what happens? Water moves in or out. In case of hyponatremia, the water will move into the cells and the cells will begin to swell. Okay? Cellular swelling. This is most notable in the central nervous system. So, brain cells, edema, neurological symptoms, they can begin with headache, nausea, lethargy, disorientation, and if not treated, can lead to death within few hours. Okay? So, how do you treat hyponatremia? Now, there is a patient, sodium levels are very low, you are suspecting that there is swelling in the neurons. What will you do? You will give him sodium very quickly, right, to bring the level back, or should you not? Any idea? In case of acute hyponatremia, you can replenish the sodium very quickly, no worries. But if the patient developed this hyponatremia over a course of days, which means it's a slowly developing hyponatremia, you never correct hyponatremia quickly. Why? Because when there is hyponatremia that evolves more slowly, the brain cells, what they do, now sodium is less outside. Okay. So, what will happen? Water will start moving in the brain cells will begin to swell. What they do to replace sodium outside, they move some other solutes outside, so the neurons will not swell. Okay. So, if you correct the hyponatremia too quickly, you are going to give the patient a lot of sodium. This sodium goes around the neurons and suddenly the osmolality will go very high. Okay. And this could lead to acute demyelination of the neurons and the patient will not survive. So, in case of chronic hyponatremia, you should not correct the sodium levels very quickly, you do it slowly. This is the recommended guidelines, 10 to 12 millimoles correction in 24 hours. So, you do it slowly. Okay? And hyponatremia is the most common electrolyte disorder encountered in hospital patients, and usually it is missed. So, you need to have a very strong clinical suspicion to pick it up, hyponatremia in hospitalized patients. How do you evaluate a patient who is having hyponatremia? Of course, you will do the blood test. You know, you have the report in front of you now. You have to first consider the validity of the result. Always, whenever you are talking about any electrolyte, you have to match the report with the patient's clinical symptoms and signs. Okay? You cannot interpret report on its own. You also check the result, how it compares with the previous test or baseline. Second step, you look at the clinical importance. Is the patient symptomatic? Okay. Then you look at the sodium levels. How low is the sodium? If it is less than 125 millimoles per liter, you don't need to worry that much. You can manage the patient conservatively. If it is less than 120, then you may need urgent intervention if hyponatremia is that severe. Also, you look at the onset of hyponatremia. From the history, you will know whether this hyponatremia has developed quickly or has it developed over many days or weeks. So, this will also inform you if there is sudden drop of serum sodium, there is increased likelihood of sensory disturbances, seizures, you need urgent medical attention because the brain cells are swelling. Okay. In case of chronic hyponatremia, which is common in elderly, usually asymptomatic, you do not need urgent action. You can prescribe them sodium tablets and gradually treat the condition. Okay. We also consider other factors like, does the patient have a known condition where hyponatremia is expected? Okay. For example, the patient is having heart failure, he is having ascites, or he is on diuretics. In this case, hyponatremia is expected, so you do not worry. All right. You consider potential of chronic hyponatremia if patients have existing relevant chronic conditions, there is no previous result for comparison. The likely cause, this will determine the appropriate action to resolve the issue. If patient is having heart failure and there is ankle edema, there is edema in the around the lower legs, so potentially the patient is having fluid overload. In this case, the hyponatremia is due to fluid overload. If, for example, there is an old patient taking thiazide diuretic, potentially this is now due to loss of sodium from the kidney. So, patient's history, how quickly, how slowly the hyponatremia has developed, other clinical conditions should also be in front of you when you are interpreting a result of sodium balance, whether hyponatremia or hypernatremia. Very important. Okay. Another thing, when you are evaluating hyponatremia in a patient, you look at the volume status of the patient. Is there hypervolemia? Normovolemia means the blood volume is normal, or there is hypovolemia. Okay. If there is hypervolemia, probably there is heart failure, liver failure, okay, and there is accumulation of fluid. If it is normovolemia, the causes of hyponatremia could be hypothyroidism or SIAD or psychiatric illnesses, okay, osmotic ADH release, etc. If there is hypovolemia, the blood volume is also low, and now you want to know from where the patient is losing water. Then you measure urine sodium concentration. If it is more than 20 millimoles per liter, okay, it means the patient is losing sodium through the kidneys. If urine has less than 20 millimoles per liter, patient is losing sodium from somewhere else, not from the kidney. So, other sources could be GI tract, vomiting, diarrhea, excessive sweating, or burns, right. So, hyponatremia together with urine sodium concentration can also provide you a clue where are you losing sodium from. Is it through the kidney or through extrarenal causes? There is another thing which you have to be very careful about. This is called pseudo hyponatremia. As the name tells you, that the blood report tells you there is hyponatremia while there is not. It is a pseudo hyponatremia. When does that occur? It can occur in many conditions. Usually when the patient has severe hyperproteinemia or severe hyperlipidemia, too much proteins in the blood or too much lipids in the blood. Let me show you in the next slide. Okay. So, this is sodium, this is water, this is proteins and lipids or proteins and lipoproteins. Normally when we measure sodium in a blood sample, right, we will spin down the cells, okay, and we will collect either plasma or serum. But this plasma or serum will contain proteins, will contain lipids as well, right. Okay. So, when you are measuring sodium in the serum, the whole serum, the value will come to 138 millimoles per liter. But if you are measuring the sodium only in this part and then extrapolating it to the remaining part, so normally when you are measuring sodium in a serum or plasma sample, okay, you measure it in the whole serum or you measure it in just the water portion of the serum, there is some difference. There is normally some difference because sodium does not mix with this portion, sodium will stay in the water part. Okay. In those conditions where you have a lot of protein and a lot of lipids, the water compartment has become smaller now, right, because more space is taken by proteins and lipids. The water compartment has become smaller in the serum. Okay. And when you measure sodium here, you extrapolate it to the whole sample, you may get a low concentration reading. So, the lab report will tell you serum sodium is, for example, in this case 108 millimoles per liter, while the sodium is normal actually. So, this is basically a calculation error. And as I told you earlier, the newer methods of measuring serum sodium will not give you this kind of false reading, but older techniques can give you false readings of hyponatremia. Now, we go to hypernatremia. All right. Increased sodium concentration, which will also lead to increased osmolarity. It can be due to, again, two possibilities. There is primary loss of water from the ECF. Just the water is lost, sodium gets concentrated. You have hypernatremia, but at the same time you have dehydration. Okay. When you do not have ADH, for example, kidneys are losing a lot of water, but not losing sodium. So, you have hypernatremia and with dehydration. Second possibility, if somehow you add sodium chloride to ECF, there will be hypernatremia, okay, and also because you are adding some water, overhydration and hypernatremia. So, two possibilities: hypernatremia with dehydration, hypernatremia with over hydration. Okay. Again, if you look at the same chart we discussed last time, hypernatremia with dehydration is diabetes insipidus, where there is lack of ADH, water is being lost, sodium stays in the blood, you have dehydration and hypernatremia. Excessive sweating, when you sweat excessively, you lose more water than you lose sodium. So, you have dehydration, at the same time you have hypernatremia. Hypernatremia and overhydration occurs in cases of Cushing disease or primary aldosteronism. Okay. You have high aldosterone. What it does? It reabsorbs sodium, right? Water also comes with it, but the primary role of aldosterone is reabsorption of sodium. So, mainly sodium level goes up, of course some water comes with it, but you will have hypernatremia plus overhydration. Cushing disease also, because Cushing disease has increase in cortisol, and cortisol at high levels acts like aldosterone. It can reabsorb some sodium. Okay. All right. Again, the list of causes, there is a long list. Excess water loss, we have these causes. Decreased water intake can happen in older people, in infants they can't tell you when they are thirsty, or in mentally impaired people. Okay. So, this is very common. Hypernatremia due to decreased water intake is very common in older people, in infants and in mentally impaired patients. Now, hypernatremia, again you have to measure urine osmolality. This will give you a clue whether kidneys are playing a role in this or not. Okay. If urine osmolality is less than 300, what does it mean? You are losing a lot of water, right? You are losing a lot of water, which means there is diabetes insipidus. ADH is missing, water is going out, sodium is staying in the blood. Okay. If urine osmolality is between 300 to 700, it could be due to a partial defect in AVP or ADH release, or could be due to osmotic diuresis. Can anyone tell me what do you understand by osmotic diuresis? What is diuresis? Diuresis is formation of urine. Osmotic diuresis, it happens in diabetic patients. When they lose glucose in the urine, glucose is an osmotic substance, it takes water with it. That is why diabetic patients have polyuria, they have a lot of urine production. They have to get up at night and pass urine, because they are losing glucose in the urine and glucose takes water with it. Okay. So, this is osmotic diuresis. Consequences of hypernatremia, opposite to hyponatremia, their cell was swelling, now cells are shrinking. Okay. Cell shrinkage. Hypernatremia luckily is much less common than hyponatremia, and severe symptoms usually do not appear very quickly. Okay. Severe hypernatremia can occur in patients with hypothalamic lesions that impair their sense of thirst. As long as the person is able to drink water, hypernatremia will never develop. Remember this point. As long as the patient is able to drink, hypernatremia will never develop. It usually develops when they cannot drink water. Okay. So, in infants or elderly people with altered mental status, when they do not drink enough water. Clinical symptoms are very vague, increased ECF osmolality, so there could be some neurological disturbances, anorexia, nausea, vomiting, restlessness, irritability, very general symptoms, there is nothing specific that you can see there. Okay. How do you interpret hypernatremia? Similar pattern as I showed you for hyponatremia. First, you consider the validity of the result. Okay. Clinical importance, is the patient having any symptoms? All right. What is sodium concentration? If it is less than 150, you do not need to do anything. But if it is more than 160, okay, then this is a medical emergency and you have to immediately manage the patient, otherwise the patient could die. Onset again would depend, whether it's acute or chronic. Acute rise of serum sodium is a significant concern and related to mortality and morbidity. So, it requires urgent hospitalization. Again, same points, consider other factors. Does patient has a known condition where hypernatremia could be normal? For example, near drowning in seawater. a lot of seawater, a lot of sodium, right? Okay. Severe dehydration, likely cause, again, if you find likely cause, you can solve the puzzle. And also remember, hypernatremia with actual decreased body sodium is the commonest cause among all the causes that I listed in the previous slides. And most common cause is excessive sweating. Most common, excessive sweating. But usually the hypernatremia will not be very severe, and after drinking water, it will go back to normal. Okay, it will not be a medical emergency unless the person is unable to drink any water or the thirst center is impaired. How do you manage abnormal serum sodium level? Just general guidelines. First of all, remember this point. Consider the validity of the result and significance of the finding. Further investigation is required if your findings do not match with the clinical picture of the patient. If underlying cause is there, you can correct that. Okay. This point, remember, rapid correction. In case of chronic hypernatremia, should never do that. Hyponatremia, general points. Hyponatremia, you try to restore balance in 2 to 3 days. Oral replacement can be given in non-acute setting, just tablets. All right. Now, quickly, another case study based on what we have covered until now, I hope. So, can you look at this and see if you can solve the mystery? What is the cause for each abnormal plasma electrolyte result? So, there is hyponatremia, there is low chloride, and there is low bicarbonate. And the patient has been vomiting. So, losing sodium and chloride with the vomitus for the last 2.5 days, and maybe not drinking enough water as well. Okay. What is the significance of the urine sodium and serum osmolality? Anyone? Sodium is being lost. Okay, so there is hyponatremia plus there is dehydration or overhydration. Skin turgor, you know. Yeah, so dehydration, right? So she is losing sodium. She is losing water, but she is losing more sodium. So, there is hyponatremia with dehydration. This is where this will fall, right? So, basically, the urine sodium is less than 20, which tells us that the loss of sodium is extrarenal. Remember that chart? If urine sodium was more than 20 millimoles, it means sodium is being lost by the kidney. This is less than 20. It's only 8 millimoles for this patient, which means the sodium she is losing is going out not from the kidney, from somewhere else. And we know in her case it is going out from the GIT with vomiting. Okay. The serum osmolality also is similar to sodium, it's low. The physical symptoms are indicating hypovolemia or dehydration. Is it making sense now? Okay. Do you want to have a little break? Much needed. All right. Thank you so much. So, 10 minutes.